Good morning, everyone, and welcome to PYA's CPE Symposium, Day 2. Before we get started, I'd like to go over a few housekeeping items. As this event is for CPE credit, there are some additional steps that we will take in order to comply with NASBA's requests. In accordance with NASBA, attendees will be provided 3 polling questions throughout each of today's presentations. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time in order to receive CPE credit for the presentation. If you encounter any issues responding to the polls, please send your answer in the questions pane, and we will document them for your CPE credit. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and post-event survey must be submitted for proof of participation today. Credits will only be earned for sessions attended in their entirety. All sessions can be joined via the same link. Today's presentations are pricing transparency using the data, total cost of IT, understanding the business case for using value-based exceptions, and clinical trials program as a new or expanded service line. You will have the opportunity to submit questions to today's presenters by typing a message into the questions pane of the control panel. We'll collect these and address them via email after the webinar, and all the presentations will be recorded and released with a copy of the slides after the event. The slides are also available in the handout section of the GoToWebinar control panel. Our first presentation of the day is Pricing Transparency Using the Data, presented by Jason Harden, Director of Business Intelligence and Analytics, and Kathy Reep, Senior Manager at PYA. With that, I'll hand it over to Jason and Kathy.
Good morning and welcome to those who are joining us for the first time today, and glad to have you back for those who were here yesterday. You have the information. I wanted to make sure that you were aware that our email addresses are in the slide deck when you download it if you need it, and you need to reach out to either Jason or I. You have our contact information available. So now let's get started in terms of what we're going to talk about this morning in terms of pricing transparency using the data. I'm going to give you a little bit of background, some history. We're going to talk about compliance with the reporting for price transparency and negotiated rate information. Going to try to link in No Surprises Act and good faith estimates, because as you start looking at charges and prices, you've got to take a look at those requirements as well. Then Jason is going to get into what we've been able to identify and see as we start looking at the data that hospitals have posted across the country, and then sharing with you some peer analysis that we've been able to develop. So let's start with that background. First of all, I got to go back. No, we're not going to start with the posting of your negotiated rates, but we're going to take it back a little bit further. And this was a requirement in the Affordable Care Act that required hospitals as of January 1, 2019 to post their charge master in a machine readable file on their website in an easy to access format. This applied to all hospitals, whether it be a critical access hospital, inpatient acute, inpatient rehab, inpatient psych. They were all required to post their charge masters on their website. There was a lot of back and forth about this, because I think the couple of things that were said. First of all, there was a requirement to provide coding information, and hospitals were concerned about posting a revenue code with a CPT code or HCPCS code because of copyright concerns with the American Medical Association. That did get cleared up for the most part, but before we had time to worry too much about it, we did have additional legislation or regulation requiring additional posting. During this earlier posting, where it was just posting your charge master, those hospitals that were paid under the inpatient prospective payment system were also required to publish a list of their charges by DRG. They are the only out of the required hospital type facilities, the critical access, the rehab, the psych, et cetera. It was those hospitals paid under the inpatient prospective payment system are the only ones that were actually subject to diagnosis related groups. So we had we didn't even have a year of this program in place before we had an executive order that was issued on June 24th of 2019 to expand transparency. Issued by then President Trump, the goal was to reduce the cost of care by increasing price competition. And this got us out of the requirement just to post our charges, but took us much further into a requirement, actually two requirements that we have to address. This was published in, the notice came out in June of 2019. We were required to be compliant January of 2021. And the first requirement was that hospitals, all hospitals, post their charge data in a machine readable file with no barriers to access. You can't ask for a patient ID, a password, for a patient to put in their name, anything like that. It was strictly overall access to anyone. And you are required to post at the individual charge level. So let's go in and say an MRI. At the MRI level, you are required to post your actual charge and then what they called the payer negotiated charge. And the payer negotiated charge was going to be for each payer plan that you have a contract with. What is your rate for that particular plan? As well as you're going to be posting your gross charge, your discount for the uninsured or the self-pay individual, your negotiated rate with the payer, your de-identified minimum across all your payers, and your de-identified maximum across all your payers. So for each charge item in your charge master, you would wind up posting up to 5 individual charges depending upon whether or not you had a specific negotiated rate for a payer. You're required to update this information at least annually and post the date of the most recent update on the file itself. And if your hospital had multiple charge masters for multiple locations, you had to post this for each. And the other thing that was very interesting is they came right out and said, we really don't expect this to be used much by consumers, but we think researchers, payers, employers, other providers are going to be anxious to want to look at the information that you've posted. So that was part one. We also had a requirement, also effective July of 2021, January of 2021, to post shoppable services. This was up to 300 shoppable services or bundle of services. Again, you're using your multiple charge levels. They call them charge, but they are really rates, negotiated rates, your de-identified minimums and maximums. And the items that you were required to post were those types of services that a patient would schedule in advance and that they might be shopping for. CMS did publish a list of 70 services that they said were very common shoppable services. And if you provided those 70, you're required to post those services. But to reach your 300, you came up with an additional 230. If you didn't provide 5 of the 70, then you came up with another 235. As long as you provided 300 distinct shoppable services, you had to post at least 300 services. Again, these were supposed to be easily searchable, consumer friendly. Not sure that when we start talking about individual items with a hospital charge master, they are easily searchable or consumer friendly, but this was the requirement. Again, no barriers to access and updating that information on an annual basis. We were given an alternative to these shoppable services, which we'll get to in a second as soon as we do our first polling question. So let's go to the first question.
Thank you. The first question is, has your hospital posted the machine readable file and shoppable services or price estimator as required by CMS, the shoppable services or price estimator only, the machine readable file only, both of the files are posted, or we have not posted either file. Remember, you must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now, I'll hand it back over to our presenters.
Okay, the majority of the folks who are participating have said that both files are posted. That's the right answer. I'm concerned about those who have said they have not posted either file, because we are now beginning to see fines actually established by CMS for hospitals who are failing to comply. The alternative that we talked about in that to shoppable services was that, let's go on here. Okay, went the wrong direction. Was that you could post an internet-based price estimator tool. This would be a tool that would require a patient to put in specific information about who they were and what their insurance was, because you would be actually accessing the payer website to go through and come back and say, this is what your out of pocket is going to be for that particular service that you are asking about. It would actually allow you to use something that queried the insurance and the patient's outstanding liability. Again, this was only an alternative to the shoppable services. It wasn't an alternative to the machine readable file that listed all of the various standard charges. There have been a lot of reports, some of them are questionable, but reports that have come out about errors in the data. First of all, some providers have only posted information at a payer level, not at a plan level. That is not the appropriate action. It should be at the individual contract level. They have posted a payer name, but they haven't posted the rate. They have just left it blank. They have, as I kind of mentioned, plan name, payer names, no plan names. It's not clear whether or not they have included professional fees. If you employ the physicians, then you're required to post rates for them as well. Some providers have used estimates, averages, medians. They've used historical data to come in and identify this is what we have typically been paid by that insurance product for that service. No, this is asking for your actual contracted rate, not a historical information on what you were paid. We are now at the point that we're seeing providers have not updated the data that was originally posted, and that you will have a price on your machine readable file that is different from the price that you have posted for a service under the shoppable services. They should agree. You are not including billing codes, your CPT HCPCS codes, your DRGs, etc. And there are some providers who have made this information very difficult to access by requiring multiple clicks to pass through the information. I actually remember checking some providers early on to see if they had posted, and in order for me to get to the screen that allowed me to look at the information they had posted, I had to click on something that said pay my bill. Well, if I don't have a bill, I'm hesitant to click on a button that says pay my bill. And so you've got to be very careful about how accessible is this to the consumer and clear and consumer friendly. There have also been, as I mentioned, I wanted to give you a little bit more information about the requirement that you post the plan information, not just a payer. So if you have an insurer, let's say Blue Cross, that has a private HMO, a private PPO, a Medicare Advantage plan, a Medicaid managed care plan, all of those need to be spelled out, not just a single rate for Blue Cross. because you don't have a single contract with Blue Cross. You've got to get down to the plan level. So let's start talking about using the data and how compliant we are or aren't. So Jason, want to take a look at this one?
Thanks, Kathy. We've selected a number of states to reflect the participants that have attended today, looking at Kansas, Montana, Alabama, Tennessee, Florida, and Georgia, looking at the percentage of those hospitals that have posted price transparency rates, but then have failed to post plan names. So they stopped at a payer level rather than going down to a plan level for HMO, PPO, exchange, et cetera. So it looks like Kansas has the highest percentage of non-compliance in terms of posting or failing to post plan name.
Thanks, Jason. Something to take a look at in terms of what you have posted. Going on to the next slide. There we go. And I
Let's
think
take a look at the next.
Wait a minute, I went too far. Okay, I was right. Go ahead, Jason.
Thanks, Kathy. So taking a look at who has posted, if you look nationally, this is as of June of 2022. We have over 4,500 hospitals that have posted nationally. When you look at this, many of the states represented here today by participants, we have actually Kansas and Alabama are tied for approximately 60% of their hospitals, 111 and 82 for Kansas and Alabama.
Thanks, Jason. There is a penalty for non-compliance. When we first had this rule come out, the penalty was $300 per day per hospital. They have now modified this as of January of this year. For those hospitals that are 30 beds or less, it stays at $300 per bed per day. They increased this by $10 per bed for those hospitals that are over 30 beds up to 550. So that your penalty is now going to range from $310 per day to $5,500 per day. And if you are a hospital with more than 550 beds, your penalty is $5,500 per bed per hospital per day. So you're going to wind up with a penalty in excess of $2 million. This is significant compared to the original proposed or implemented $109,000 per day. There is a group called patientsrightsadvocate.org. You might have heard of them, particularly if you've watched the Super Bowl or the Oscars or any of those good things, because they do have ads that address the requirements for hospital price transparency, urging consumers to check whether or not their hospitals are in compliance. They have also published their second hospital price transparency compliance report. The second one did come out in February. One thing that I want you to recognize is patientrightsadvocate.org is not CMS. They are not related to a government. They are not government watchdogs looking at what you are posting or should be posting. They have identified some errors, not all of which are errors. That one thing I think is interesting that they mentioned is that the number of insurance plans on the contracted rates does not match those insurers that you have listed on your website with whom you participate and have a contract. So that's something that I think is important to check out. There are still some providers who are requiring personally identifiable information to get into the machine readable files. Again, you can only do that in the case of the price estimator. Some providers are posting a price range. They are posting that this particular service is going to range from $50 to $212. No, you can't do that. You must include an individual rate for an individual service. And one of the things that in the transparency compliance report that was identified as a problem by Patients' Rights Advocate was putting a NA in a field. Now, blank is inappropriate, but NA isn't. CMS has actually published in response to a question that using NA in a field is appropriate, because if you truly don't have a contracted rate for a particular service, then NA is the right way to indicate it, not including a blank. So let's go to our polling question number 2.
Thank you. The second question is, what is the basis of the new proposal to increase the penalty on providers who are non-compliant with the posting requirement? Flat rate per diem for all hospitals, rate that varies by bed size, or rate that varies by the number of items in your charge master? Remember, you must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now, I'll hand it back over to our presenters.
Rate that, oh, I hope it's not going, you're correct when you say rate that varies by bed size. That is correct. It is not a flat rate per diem for all hospitals. That was the original proposal. And it does not vary by the number of items in your charge master. That would be a nightmare because I could picture that response. Going on to the next, let's talk a little bit about surprise billing and good faith estimates. I'm just going to tie this into this discussion of price transparency because of the requirements to now make available a lot more information about our charges to consumers in what I think is actually even a more consumer-friendly manner. Just as a quick refresher, under surprise billing, this was a requirement under the well, it was a part of the Consolidated Appropriations Act of 2021, effective this year. But the requirement is, first of all, for emergency services, that if the patient is presenting to a facility, meaning a hospital, a critical access hospital, an ambulatory surgical center, et cetera, and the facility is out of network, and the physician is out of network, it doesn't matter. There is going to be no balance billing for that particular patient because it is an emergency service. If the facility is in network and the physician is out of network, there is still no balance billing because it is an emergency situation. In the case of an emergency, there is no ability for any participant, provider, or facility to balance bill. When we talk about what is an emergency, we are using the EMTALA definition of emergency plus any post-stabilization services, such as admission to observation, additional outpatient services, and inpatient stay. If the treating physician determines that the patient cannot be safely moved to an in-network facility using non-medical transport, okay, then that has to be covered as a part of that emergency service, and again, no balance billing. Now, this is a potential issue with downstream providers, and it is a concern related to some of the current billing parameters that are out there, because as an example, let's take a patient who was treated in the emergency room for respiratory concern. Patient was admitted to outpatient observation. It was what the order was from the emergency room physician, and then was treated in outpatient observation by a hospitalist. Well, that service is an emergency service. Physician did not feel the patient could leave in non-medical transport, but when the hospitalist submitted his bill, there is no connection on the hospitalist claim to indicate that this service originated in the ED. And therefore, we run into an issue right now with the current billing situation that some providers are getting notice that they can balance bill when the law says that they can't. So we are concerned that that be addressed and be addressed soon so that consumers are not balance billed inappropriately. Also, under the surprise billing requirements for non-emergency services, recognize that if the facility is in network, then a provider who is out of network cannot balance bill. If the facility is out of network, not an emergency, then anyone can balance bill. The provider, the facility, balance billing would be allowed. If you're going to balance bill in that particular situation, you do need to have consent from the patient to balance bill. So you're going to have an opportunity for the patient to have selected their provider in advance. Most likely this is going to be the surgeon. You perhaps are in network with XYZ facility and you select a physician who is on that staff who is the best in doing the particular service or procedure that you want. You agree with him to be balance billed because he is out of network. This is a non-emergency, that can happen. There are certain hospital-based physicians, your neonatologist, anesthesiologist, pathologist, emergency rooms physicians, etc., who cannot get consent to balance bill. Even in the case of a non-emergency service, they can never ask for consent to balance bill a patient. So recognize that we do have very limited opportunities for a patient to be balanced billed under this particular scenario. But also included in the legislation related to surprise billing was the requirement to provide a good faith estimate. And there is a requirement that you provide a good faith estimate of the charges, both to those patients who will be balance billed and also to self-pay patients. Right now, only in force is the requirement that we provide that good faith estimate to the self-pay patient. This is not just an uninsured patient. It is someone who does not want you to bill their insurance, where they have insurance, but it doesn't cover the service that they are receiving, etc. And recognize also that this requirement related to the good faith estimate applies not just in facility settings, but to clinicians in their office settings. If they are seeing a self-pay patient for a scheduled service, they are required to give a good faith estimate of what the bill is going to be in advance. If the service is scheduled at least 3 business days in advance, you've got to provide that good faith estimate. And this is going to be, as I said, this is going to be in your facilities and in a provider's office. Now, why do I raise this when we're talking about price transparency? Because there is a requirement under the good faith estimate provisions that the scheduling provider, who could be the hospital or ambulatory surgical center, it could be the physician, is right now required to provide a good faith estimate for his or its services to the patient. But also, beginning in January 2023, you're going to have to provide information related to any co-providers. So if I'm the hospital and I'm scheduling services, right now I'm giving you a detailed good faith estimate of what my charges are going to be. In January, I am going to have to turn around and ask the physician for their information as well. Turning it the other way, if it is the physician who is doing the scheduling, in January, I am going to have to provide the physician within 1 day my good faith estimate for the service that is going to be rendered and what my costs are going to be. So we got to start looking at our charge information, our price information. If I am going to be providing this to my physicians and others, how reasonable is our data? So this is why we really want to get into the discussion of using the data and what it reveals. Beginning in well, I guess I should say right now, you are listing on your good faith estimate all the items and services for which you bill. This is going to have to be a dollar amount for each item, not a range of rates. You're going to have to show your rates inclusive of discounts. So even if you are dealing with a patient who is uninsured and the bill will be zero, you still have to give them a listing of those charges with the discount reflective. We think this is about time to start looking at your charge master and your self-pay rates, evaluating them for how do these look, how do they compare to others, and what is the consumer seeing. So let's get into actually using the data. So the first area we're going to look at is price and rate analysis. Before Jason provides you some data, particularly for some of the locations that are on this call, a couple of things just to let you know that this isn't going away. The Medicare Payment Advisory Commission in their March report to Congress said that it's imperative that the current fee-for-service payment systems be managed carefully and continuously improved. Medicare is likely to continue using its current fee-for-service payment systems for some years in the future. Think outliers and what your charge is for an outlier, for a claim that becomes an outlier. This fact alone makes unit prices, their overall level, the relative prices of different services within a sector, and the relative prices of the same service across sectors of critical importance. Constraining unit price increases can induce providers to control their own costs and to be more receptive to new payment models and delivery system reforms. And then on the heels of MedPAC making that statement, we also had a report that came out in May from RAND about private health plans and the prices paid to hospitals by private health plans. And the RAND report said that some states had relative prices below 175% of Medicare, while other states, Florida, South Carolina, West Virginia, had relative prices that were at or above 310% of Medicare. In 2020, across all hospital inpatient and outpatient services, including both facility-related professional charges, employers and private insurers paid 224% of what Medicare would have paid for the same services at the same facilities. So Jason, do you want to share what we're seeing for those facilities and comparing what Medicare is paying compared to what private payers are paying?
Sounds great, Kathy. Thanks. All right, let's dive into the data.
There we go.
Okay, so the way we have the remaining slides broken down, we're showing price in terms of bill charges, and then we transition to negotiated rates, focusing more on commercial rates. This first slide, it is showing, for many of the states represented here today, showing the average reimbursement, average negotiated commercial rate as a percent of Medicare for an MRI of the brain, and then looking at average negotiated commercial rates as a percent of bill charges. So we can see on the top chart, we see that Florida is 680% of Medicare on average for commercial rates as a percent of Medicare for an MRI, where Montana comes in at the lowest at 523%. In terms of commercial rates as a percent of bill charges, Florida is the lowest, with Montana being the highest. So some variability from state to state. Looking again at price, at bill charges, we're looking at the minimum, maximum, median, and average for an MRI and an EKG. So what we see here, we see that Florida is both the highest for the MRI and EKG. So at almost $6,000 on average for an MRI, and just under $1,000 at $774 for an EKG, where Montana comes in as the lowest, actually, in terms of pricing for both of these procedures.
And one thing I just want to mention about this data, first of all, this is the data that providers have posted. And this is truly your charge information. It is what you have said. This is what I charge for this code 70553 or 93005. It does not include professional component. it is your straight charge for the service. So I'm just going to use as an example the 12 lead EKG. A 12 lead EKG is a 12 lead EKG no matter where you go. Whether it's in a physician's office, whether it's in the hospital, it is the same service. Look at the range of prices for that particular service. If the median rate in Florida, as an example, is $425 for a 12 lead EKG in a hospital setting, then I mean, $44,000 for another provider in the same state.
Then we looked at a system to see if we saw variation in pricing within a system. Here for the same CPT, MRI of the brain, we're looking at a system of 9 facilities, and we see that there's quite a bit of variation, ranging from just over $1,000 in billed charges up to almost $10,000 in billed charges.
One of the things that in working on this information that we have identified is, yes, people are starting to look at the data that's been posted, and they are going in and they are doing evaluations and modeling. There is a site that has been developed for the consumers. It was originally put in place to help consumers compare prices for COVID tests. They are now moving into a number of items, shoppable items, services, to allow the consumer to better identify lower price providers. The name of the company is Goodbill. There was an article on them in Crane's Detroit Business. But Jason, just share some of the information that you have for Atlanta.
So looking at the same CPT, MRI of the brain in the Atlanta market, we wanted to look at the variation of the facilities that have posted rates in the Atlanta market. So you see quite a disparity. You see anywhere from under $2,500 to in excess of $7,500 and anywhere in between. So it's just interesting to see the variation in a particular market.
And again, the facility service only. It is not bringing in the radiologist or anyone else. And next, let's start looking at rate analysis, because when we were initially looking at charges, but now we're going to get into your rates and how, if you start looking at the data that is available now with the postings that providers have done, forgive that background noise, this will help in negotiations. So Jason, I'll turn it.
Great, thanks, Kathy. So previously we were looking at billed charges in terms of price. Now we're transitioning the remaining slides, looking at negotiated rates. So this has been filtered for a few things, one of which is for commercial payers. So we also have Medicare Advantage and Medicaid Advantage data that has been posted by facilities. This has been excluded. One other thing to note is there are outliers in the data. The data is a representation of what's been posted by facilities. So we have seen anything from a $300 heart transplant to a $2.2 million hip joint replacement. So our attempt to cut through that noise is we've ranked each CPT and DRG across the nation, and we've removed those outliers so we can make more sense of the data that has been posted to make it more meaningful. As Kathy mentioned, the data could be used by plans or providers for future negotiations, for contract renewals, or in independent dispute resolution. What we're going to focus on the following slides, we'll be looking at DRG 195 for pneumonia for the same states that we looked at previously. So what we find here is the average of the states. It ranges from $6,700 to $9,200, the average commercial reimbursement, where the outliers have been removed overall. We also have the minimum and maximum listed as well. In the subsequent slides, what we're going to show is drilling into those averages by state. We've then showed by payer the average negotiated rate by payer within each core-based statistical area. So here for Alabama, for example, we're going to have Birmingham, Enterprise, Selma, Dothan, etc. So what we can see is Aetna is purple. Blue Cross.
Jason just mentioned that under other, where it says other, that is going to be your non-CBSAs. That's going to be your rural markets within the state.
It is. So on this slide, we don't have that. On a subsequent slide, we have that listed. This would be
No,
all of the other
it is here.
payers. These would be all of the other payers that would not be specifically called out. So we have the major payers. So we have Aetna, Blue Cross, Cigna, Humana, and United Healthcare. And then we have grouped all other payers that would traditionally be lower volume. So for instance, here we have Enterprise Alabama. We have the highest rate that we see, the highest average negotiated rate would be for Aetna and so on, with the ability to filter by specific payer name or code type, or this confidence interval can be modified to exclude or include outliers as we define. Later on, we'll have markets outside of a CBSA that will categorize as other in the slides to follow. Here we're looking at Florida, so we can see for the same DRG, for simple pneumonia, an average of $9,200, and we can see the variation throughout each core-based statistical area throughout the Florida market. In Georgia, Kansas, and Montana, and Tennessee. And we'll have a link at the end of this slide if you want to see in further detail this dashboard. There's a QR code that you can scan and select your state and look at the rates. This next slide, one thing that we wanted to look at, Kathy and I were interested in what the variation is in reimbursement for urban versus rural facilities. So we thought it would be interesting to look at the same DRG pneumonia that's often provided in both urban and rural facilities and look at the average reimbursement difference between commercial payers. And what we found is for the average for pneumonia in Florida, we saw that rural as a percent of urban was 74%. So we saw $7,100 as the average reimbursement for this DRG compared to $9,500 in an urban setting. When we look at Montana, we see that it's about the same as what we find here. It's still slightly less when we compare rural to urban.
And one of the things that's important about this is that when we start looking at the viability of small rural hospitals, if they cannot contract up to the rates that the urban hospitals and not too far, far away are able to get, then you know that this is going to have an impact on their sustainability over time.
Great point. And here we're showing the median for the same DRG. And here, as Kathy mentioned, for other, we're showing the rural areas that are not defined within a core-based statistical area. So you can see that they're added to the following dashboards for the same states. We'll just quickly go through here.
Go back one. Go before we go to the polling question. Jump back. I think this one more. I think it was. Nope, one more. Okay, this one. In Georgia, I think it's very interesting to note that with Aetna, a hospital in rural Georgia has been able to negotiate the highest rate for this particular condition compared to all of the rural urban areas within the state.
Good point. Okay, we're now ready for our third polling question.
Thank you. The third question is, as of June 2022, approximately how many nationwide facilities have published negotiated rates? 1,000, 2,250, 3,500, or 4,000 plus? Remember, you must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer. Thank you for participating in our poll. Now, I'll hand it back over to our presenters.
So 4,000 plus, it's approximately over 4,500 facilities as of June have published negotiated rates.
Published, but doesn't mean that they are absolutely correct or have been updated.
Good point. So the next slides, I wanted to show some examples of how we found useful use cases to use the data. In this example, it's a de-identified dashboard allowing us to compare negotiated rates, the minimum, maximum, and average between several health systems, with the ability to then drill into a facility and then into the payer to compare rates. So for instance, for Blue Cross Blue Shield, we could compare reimbursement for a specific service. So we could select the service and then see if a specific system, how it compares in terms of the reimbursement that's contracted compared to other peer groups that are selected in the dashboard. Another example that was pretty neat to work on with the data is looking at reimbursement for children's hospitals. We were approached by a children's hospital that believed they were getting a lower reimbursement than they thought other competing facilities were. So we looked across the nation and compared rates. We had approximately 36 children's hospitals that had posted at this point in time. And what we found is for the majority of the DRGs and CPTs, where they had sufficient utilization, and many, if not all circumstances, their reimbursement was on the lower end when compared to the other children's hospitals that we showed in the dashboard. So that was another way that it made the data useful in terms of comparing where that one facility was at compared to other children's facilities across the nation.
One thing before you go on and before we wrap up that I just wanted to mention and get a little dialogue with you, Jason, going. We also now have the requirement to post for the payers to post. Effective July 1, the payers are required to post information in terms of their negotiated rates with providers, with employer plans, et cetera. That information is out there and is available now. I think from what I've understood from you, it's massive. But I think we now, from a provider perspective, we're going to have one more issue of comparison. I mentioned that, we've got the concern with information that is on the machine readable file being different than the information that is on our shoppable services. Now we have concerns that the information that we provide in a good faith estimate is different. But what happens if all of that is different than what the payer has actually posted? And are you checking this? And is this something that you need to be aware of if the information you've set as your negotiated rate is not what the payer itself has posted? Jason, you're going to start playing with that data soon, aren't you?
I am. So roughly half the payers have posted. It's significantly larger than the initial price transparency requirement. It's 500 terabytes of data that they currently have posted so far. So it's pretty massive undertaking in terms of analyzing that data compared to the data that was published by the various hospitals. If you're interested in looking at the dashboards that we showed today, visit the QR link, select your state, and you can compare at the various CBSA levels average negotiated rates by payer. And feel free to reach out to Kathy or I with any questions.
Thanks, folks. We'll turn it back to Trevor.
Thank you, Jason and Kathy. We will now take a short break. The next presentation will begin at 12:05 p.m. Eastern Time.